Next, to continue our exploration of pediatric experiences, we have Jane Yeager from UCSF. She is a service designer at UCSF who works across disciplines to improve patient experiences. And I'm really looking forward to her talk. She's a HXD veteran, and so happy to have you on stage today. Thank you and welcome, Jan.
Thank you. So today I'm going to be talking about a work in progress focused on helping young patients growing up with chronic illness achieve lifelong wellness. So UCSF has 34 pediatric multidisciplinary and multi-specialty clinics, and last year 14,000 patients were seen at least twice in the same specialty clinic. We serve all of Northern California and the Central Valley. So the problem is that taking care of chronically ill children in a healthcare system designed for acute care doesn't work very well. In academic medical institutions such as UCSF, the clinics are usually disease specific, and so they're pretty siloed, which puts a burden on patients and caregivers to coordinate and navigate across those clinics when their children are needed to be seen by multiple specialists. There's also varied staffing and payment models, which means some clinics have specialty or subspecialty staff that others do not. And this is not really well aligned with chronic disease care delivery when these kinds of services are needed by all. So that does create gaps in care due to limited access. Services that enhance wellness are typically considered extra, and so they're not systematically provided, and oftentimes payment models don't support them. So there are missed opportunities for optimizing long-term health. So this vision of achieving lifelong wellness for pediatric patients is stemmed from, Dr. Emily von Shaven, who's a pediatric rheumatologist. And she would really like to shift the care paradigm by thinking about this way of caring for people from a long view perspective and creating a health system that maintains that long view. And the reason why she's interested in doing this is because chronic illness is complicated and it lasts forever. So not anybody is really focusing on what happens as these children age and into adulthood and the kinds of needs that they might have. So this takes a life course perspective and addresses the rising rates of chronic illness. So typically, when you have an onset of an illness in childhood, survival rates are typically pretty short. But as they have advances in therapies, there are of course, extensions in that survival rates, but that also brings about new morbidities as children age into adulthood and carry their disease with them. So the model we're proposing provides innovative care across diverse diseases and features sort of service lines that can be brought in and out according to that affect children who have chronic illness specifically, like being able to transition to adult care and create a similar type of ecosystem of care that they had as they were children. And all of this centers around these 8 domains of wellness that we have identified. So the team that we have, rather extensive set of collaborators and other stakeholders that we're working with. So we have the core design team, which consists of 3 physicians, program manager, and myself. We are working with a mental health group, and this is physicians, psychiatrists, nurse practitioners, social workers, and we're really looking to them to help us make sure that everything that we do is trauma-informed. And I'm pushing towards expanding that vision of what trauma-informed care means because I think most people think about it externally outside in the child's home or their external environment. And there are lots of medical procedures that are very traumatic. So thinking about any kind of stress-related experience that a child has getting their medical care, we should be accommodating that, thinking about how we can mitigate it or avoid doing that when we're working with them and they are coming through our service line. We have an advisory council that we use for progress reporting and also to give us guidance on the work in progress. We have access to two really wonderful volunteer organizations within UCSF that we can tap into for collaborating and co-creation, testing out ideas and getting their feedback. And then our main group that we've been collaborating with is this clinical care delivery and design, which we are working on to co-design the services. We have a physical space that we will be designing once we're allowed to do that, and then access and navigation to wellness services. So from the outset, the idea was to introduce human-centered design practices into the work to ensure that the center embodied the perspective of patients and families. And this was done intentionally. This visual we use in all of our communications since it's an unfamiliar experience for stakeholders, and we wanted to keep them engaged in the process. So when we started this in January 2020, our expectation was that we, similar to other service design projects that we've done at UCSF, we'd follow a standard process going across this journey, 4-phase journey, and end up with a service that we could pilot and test out the operational aspects of it as well as the service experience. But what really happened was after this initial phase of discovery that was done between January and March, this is the output from that, which was basically a executive summary that was presented to the donor who is funding this work for us. And because we couldn't really address the physical space at this time, we chose to focus on how we might start with this facilitating access through the needs assessment. And developing this needs assessment was really focused around this artifact idea of some kind of an intake mechanism, like a document of some sort, but it had these really powerful sort of features associated with it. So it was flexible, it was empowering, it was a living document for use across time, and that is a guide to wellness services for families and patients. And so the question that we were asking ourselves was really focused around the design aspects of that. So what kind of content should be included in this intake? What does a baseline profile of a child look like? How robust is that? How can content be delivered in a way that's accessible to different age and developmental levels and different users? How do children and adolescents and parents interact with this over time, since we wanted this to be something that lived across their life? And we know that the demand for information in any medical setting is just so overwhelming. Families just are weary of constantly having to give information up about themselves. And so this idea of things, taking it from some sort of horrible experience that people dread, having to give out one more shred of info, repeat the story one more time, something that's really one-sided and benefits the institution, but not so much the patient or the family. It's really a chore. It's very disruptive, and make it something that's much more engaging and interesting for the patients and the families, especially if we expected them to want to do this over time. So we realized we couldn't focus solely on the artifact without thinking about the conversation surrounding it. So instead of viewing this as a sort of variation of a medical interaction where it's controlled by the provider, it takes place at a very compressed time frame in one moment of time, that we had to think about this more holistically. And so we sort of use this typical framework in a conversation of the context, creating a shared language, understanding how we are going to exchange and engage with each other. And so we began to think about, okay, what does this look like? And we ended up going back to the discover phase into multiple inquiry types of inquiry into how to answer the question of how do we create the conditions for a wellness conversation to occur. But we realized in doing this that we had to be almost prescriptive in how we were going to do this in order to be able to understand what it was that we were talking about, since conversations are so ephemeral. So we're beginning to now get agreements around what this looks like and sort of start to populate what we're talking about here with making sure that we're situating this experience in the child's life journey. Like, where are they now? What is important to them now? To be sure to do it in a way that emphasizes their strengths. To use some, evidence-based methodology like motivational interview or shared decision-making, and be sure that it's always fitting into the context of the child's life as we make a plan for their wellness and the things that they are interested in working on. So we also know that we want this to live over time. And so we're kind of balancing what we're talking about with the mechanics of the operations of running a clinic, essentially, or running the service within an academic medical institution. And so how do we take what we learn in this beginning of the conversation and take those principles and carry it across the journey as we do check-ins or follow-ups, how we reevaluate plans down the road and build things into the conversation that continue to support and present this from the child's perspective and not just from the institutional's perspective. So there were a number of learnings that came out of this. Primarily, managing a large stakeholder group was as complex as the work itself. We had to set up a cadence of meetings, particularly with the care delivery design group, of monthly meetings, but it really was hard to maintain any kind of momentum across the work groups, including our core team, because we only met weekly, and have work move forward. And we were always planning meetings on the fly at the last minute, and it was really sort of not very well thought out, therefore not run very well, and the outputs were not as good, it's sort of garbage in, garbage out kind of a thing, and that was pretty frustrating. Also, working within the realities of providers' day jobs of caring for patients meant they had minimal access to them between meetings to move things along. We tried out giving people homework to do in between meetings. We also tried to carve out very small tasks that people could do separately between meetings, and nothing really worked there. Teaching the core team the art of synthesis was really challenging too. We kept getting all this data, collecting all this data, but it was really hard to, only within the confines of an hour, do any sort of meaningful reflection on that and what does this mean, and create, do sense making and sort of navigating through that data to come up with requirements or feature sets and things like that. So it was pretty challenging to work in this way for a designer. There's also this reconciliation between domains of knowledge and practice. So it was really challenging for stakeholders to acquire a design mindset and kind of shedding that expert frame, even though they work with children constantly. I just found there was a little bit of a gap in feeling empathy from coming at it from a patient's perspective or a child's perspective. And I think when we did have these sessions with the Patient Advisory Council and the Youth Advisory Council, it was always eye-opening for my team with providers to hear it from their perspective, to hear directly what the patients and parents were experiencing. So being able to recognize these challenges outside of the institutional experience, and the idea of making the unfamiliar familiar when we're introducing human-centered design tools and way of working was trying to get people to attend to the design process and not just jump to a solution, to use the data to inform the needs and use those needs to inform the design solution. navigating the vocabulary of design also was challenging. And, even something like, what does a requirement mean? Or what does a feature mean? What's the difference between a feature and a requirement? So it was trying to navigate, negotiate that so that we could have a common working vocabulary. I also found that providers are very verbal communicators. And so when we talk about things, they're always verbalizing it, but it was sort of like, well, what do you mean by that? And so I think I'm getting them used to the idea of visualizing. So instead of talking about it, let's model it. Let's do a journey map. Let's do some kind of a diagram of the workflow. And also getting used to new ways of thinking and seeing. So for them, it's like, I don't even know what an experience is. I can't imagine what that looks like. It was also challenging to design for such a heterogeneous population. So really challenging to design, to create personas or scenarios. It was just really hard. And we were not successful in doing something without getting a lot of pushback. Patients are incredibly complex with many variables to consider, and they should probably be considered in concert with their parents, and it should be a dyadic kind of a persona, or the scenario should be developed from both the perspectives of the parents and the children, but that's sort of difficult to do because also oftentimes there are divergent needs that are going on there. So how do you address one over the other, and they don't necessarily reconcile? And labels were seen as othering, and I'm sure that a lot of people, in today's DEI environment, that it is challenging to do things in a way that are sensitive to being inclusive and not kind of pointing or labeling to people. And this was just an example. We tried to do some stress testing of a journey, and we just sort of took 3 scenarios and tried to understand what their needs would be along the way. And this labeling that I did of high touch patients, low resource patients, or high functioning and engaged patients, we thought would be sort of people that could self-serve, just completely derailed the conversation that we were trying to have about this. And it was just really kind of eye-opening to me that people are highly sensitized to the way that we are talking about our patients and families. So going forward, we're going to face some tensions as we're creating this new thing that really is, in our understanding, doesn't exist anywhere else. It's chronic illness centers. How do we operationalize patient-centered solution within the bounds of available technologies and capabilities at UCSF? So we would love to do things that are, apps specifically designed for children to access, or even have access to their own information. And it just, it's just not capable of doing that at this point. How do we facilitate culture shifts associated with implementing different care models? So getting people to think more long-term and consider a child's care through that preventative lens, and help us be able to facilitate getting children into wellness services and connect with those things to support their overall health. And how do we succeed when current healthcare policy and financial models are not aligned with this approach of care? So, a lot of insurance don't pay for wellness type services, and how do we get that to work in our favor? And that's it. Thank you.
Again, thank you so much. I'm so sorry about the presentation.
Yeah, sorry guys.
The way that it was, you rolled with the punches, and it came out great. I really appreciate you sharing your insights with this community. It's just phenomenal.
Okay, thank you.
Thank you.